everyone. Good afternoon. Hello. Yes, so we are going to start very, very soon. So my name is Maureen. I am a senior executive at Mind Science Center. And it's really my pleasure to welcome all of you to the third edition of the Living with Dementia Webinar Series, Doctor, Am I at Risk of Dementia? So this webinar series is made possible thanks to the generous donation from Professor Kua Ee Heok and all of our donors. And on behalf of Mind Science Center, I would like to thank everyone who has helped us achieve this mission. So with us today, we have Associate Professor Rathi Mahendran, Senior Consultant at the Department of Psychological Medicine at NUS and NUH. We also have a special surprise guest today who is not in the poster. We have Associate Professor Tan Tin Wee, the Chief Executive of the National Supercomputing Center of Singapore. So I will now pass the time to the chairperson of today's webinar, Tan Geok Kin, Professor of Psychiatry and Neuroscience, Professor Kua Ee Heok. Okay, Prof. Kua.
Thank you, Maureen. Welcome to this series, Living with Dementia. Before we begin, I want to thank our benefactor, Professor Kua Ee Heok, who has sent us a donation to allow this program to be broadcast to, I think today I'm told there are almost 900 people have registered for this webinar, and people across not just Singapore, over in Malaysia, as far south as Australia, and also I'm told even America. So welcome to all of you. It is a beautiful Thursday afternoon here in Singapore, and we are very excited to listen to the speakers and to all your comments. I realized that whenever I run a clinic for my patients, just before it finishes, the caregiver would ask me, Doctor, am I at risk of dementia? Yeah. So I'll tell him that we have just about 1 minute left. There's no time to answer your question. And maybe we should have a discussion, a webinar, or even a seminar on this very important question, relevant to many people's life. I'm glad to have for us today Professor Rathi Mahendran. She is very well known here in Singapore, a very experienced psychiatrist, was previously the chairman medical board or the medical director of IMH, and she's done extensive research on aging and also on women. And so this area is close to her heart. And so shall we kickstart? Professor Mahendran, you're ready? You'll tell us something about dementia and then and who are the people at risk and more at risk. Okay, it's all yours now, Rathi.
Yeah. Okay, thank you, Prof. Kua, and good afternoon, everyone. Can we move on to the next slide, please? Okay, great, thanks. I would like to start really by highlighting that for the diagnosis of dementia, there are two criteria which must be met. First, the history and presence of cognitive decline and deficits, and secondly, functional decline. I'll elaborate a little bit more. While everyone is familiar really with memory decline, there are actually several other cognitive areas or domains, as we refer to them, in which decline can occur in dementia. And altogether, there are about 6 domains. In the domain of memory and learning, recent memory fades first, and it recedes back in time from there. It becomes increasingly difficult for an individual progressing to dementia to register and retain new information. And there comes a time really when the individual recalls only past events. The individual also, unfortunately, loses insight or awareness of his or her memory loss. The second domain to know about is the language domain. And here, difficulties can occur in speech production, being unable to find a word, name an object, understand words, and in grammar. The third is attention domain. A dementia there is results in increasing distraction, trouble with focusing and paying attention, and hence multitasking becomes a real problem. For example, even a simple thing like having a conversation during a meal might be difficult for an individual with dementia. The fourth area or domain is executive function. Now, this refers to higher order skills, which are very important for all of us. Things like thinking, planning, organizing, and decision-making. So deficits here may result in poor judgment and affect an individual's abilities and dependence. The fifth domain is perceptual motor functioning and refers to understanding what one sees. For example, deficits in this area would result in a person seeing a toothbrush, but not connecting that with brushing one's teeth. And the last domain, social cognition, refers to the ability to recognize others' emotions, intentions, and behaviors. When there is a deficit in this area, an individual is unable to filter what he or she sees in others, their expression, the tone of voice, words, intent. So these 6 cognitive domains are important, and keep them in mind as we review slides later on. The second important criteria I mentioned is functional decline. In the early stages of dementia, difficulties appear in what we term instrumental activities of daily living. So difficulties in shopping, in doing household chores like cooking, cleaning, doing the laundry, using the phone, handling money, handling banking, managing their own medications, traveling independently. And as the brain deteriorates further, functional decline appears in activities of daily living. For example, grooming oneself, dressing, bathing, showering, feeding, walking, and so on. So for the diagnosis of dementia, remember, deficits in cognition and functioning must be present. Nowadays in psychiatry, we use the term major neurocognitive disorder for dementia, a term that better actually reflects the neurological and cognitive defects that occur in this condition. However, for the talk today, I will continue to use the term dementia, I think, as the majority are likely to be familiar with it. Okay, can we move on to the next slide? Next slide, please. All right, so in the next couple of slides, I'm just going to list the various types of dementia that we diagnose in psychiatry, and there are 12 types altogether. So here we have Alzheimer's dementia. In the new terminology, doctors might refer to this as major neurocognitive disorder due to Alzheimer's disease, right? Then we have vascular dementia. As the name suggests, it has to do with blood vessels in the brain. Parkinson's dementia. Here, the problem starts with Parkinson's disease and then eventually leads on to the dementia. Frontotemporal dementia really is a dementia in which the primary areas in which the atrophy occurs are in the frontal lobe and in the temporal lobe. And then there is Lewy body dementia. All right, next slide. We also have a category of dementia due to multiple etiologies. And this diagnosis is used in cases where 2 types of dementia occur together. For example, Alzheimer's disease and vascular dementia, or frontotemporal dementia and vascular dementia. Dementia due to traumatic brain injury, I think this explains itself. So a very serious injury to the brain, fractures of the skull that cause penetrating injuries, bleeding in the brain, of course, can lead to dementia. And we'll revisit this area later on. Dementia due to another medical condition, and there are several medical conditions actually which can result eventually in dementia. Example, brain tumors. All right, severe heart failure causing poor circulation and insufficient perfusion to the brain, as well as reduced oxygen levels in the brain. Infections such as neurosyphilis can damage the brain. Late stages in several different organ failures, for example, end-stage renal failure with very severe renal disease, right? Liver failure. All of this carry the risk of cognitive impairment and dementia. Dementia due to substance or medication use. Here, a well-known cause in terms of the substance is alcohol. So very chronic and excessive use of alcohol for many years, and especially if it is complicated with liver disease, does contribute to dementia eventually. Medications, things like use of sleeping pills, right? Especially if it escalates and continues into old age, can contribute to impairments in memory, learning, executive functioning. And then, of course, we have the whole range of drugs of abuse, things like amphetamine, marijuana, and drugs like that, which, if they are continued to be taken throughout the years into old age, again, carry the risk of dementia. Next slide, please. Okay, and then we come to the really rare types of dementia, and we won't go over this again, except just to highlight a few important points. Dementia due to HIV infection does occur, particularly as the illness progresses to AIDS, where there will be impaired executive function, processing speed is affected, and of course, attention, concentration, all become major issues for the individual with AIDS. Huntington's dementia really arises from Huntington's disease, which is a genetic disease, rare occurrence, but runs in families. So very quickly when there's this illness, it's easy to pick it up because in families who carry this risk, right, the illness starts very early. There is a juvenile variant, and there's another variant that appears around about 40s. And it presents with neurological problems, involuntary jerking movements, cognitive decline, as well as neurological deficits and emotional changes. So that's Huntington's dementia. And finally, dementia due to prion disease. Now here it's caused by a transmissible agent known as prion, right? They cause damage to the brain, but it's very widespread. And we refer to this as encephalopathy. So many areas of the brain are affected. And also, unfortunately, it is a very rapidly progressive dementia, and many people succumb within 6 months. Now, some of you might recall that in the 90s in the UK, there was an outbreak referred to as mad cow disease. Now, it was a bovine strain of this prion that caused that outbreak. Okay, so dementia due to prion disease, rare, but unfortunately quite fatal. All right, next slide. So now we come back to some of the dementias that we want to focus a little bit more on. And the first of this is Alzheimer's dementia. Let me quickly present to you the clinical features, right? We do know that in Alzheimer's dementia, the onset is often insidious. There's a very gradual progression of cognitive and behavioral symptoms, right? And there are two subtypes, amnestic type, and here it's quite clear, the impairment is in the area of memory and language learning. Non-amnestic type, when the problem really starts in the visuospatial motor regions, and then speech also is affected, and at the later point, memory becomes affected. So if you look at the pictures below, on the left, we have some scan pictures of the brain, and on the right, more diagrammatic presentation. Now you'll see the normal brain very nicely well formed, but the brain with Alzheimer's disease in the later stages, it's very much shrunken and atrophied, right? And you will see that the spaces within the brain are very widened, right? The ventricles become enlarged, and the actual cortical matter is very much reduced. And that's how the changes occur in the brain, and then that too contributes to the problems in the presentation, in the clinical symptoms, as well as the cognitive decline. Now, the basic pathology here in Alzheimer's dementia is abnormal deficits of proteins which form beta amyloid plaques in the brain matter and tau tangles within the neurons in the brain. Okay, so that is a brief snapshot of Alzheimer's dementia. Let's move on to the next one. Vascular dementia, basically the issue, the problem is with the blood vessels supplying the brain. And here again, there are two main types, stroke related, right? And as is very clear, and I'm sure you have known people who have had a stroke, what happens is there's an abrupt cutoff in the blood supply to the brain because either a vessel is narrowed or there's a clot there, or a vessel with an aneurysm has ruptured and there's bleeding into the brain. Okay, and what happens is a very acute onset and rapid cognitive decline, which occurs, and then as things stabilize, there will be a period of stability. All right. If a stroke recurs again, then again there's another sharp further decline, and then followed by a period of stability. And it's because of this that we refer to the progression in stroke-related vascular dementia as a stepwise progression. All right, so different from what we saw in Alzheimer's disease, which is a gradual deterioration. Here it is a stepwise deterioration. The other type of vascular dementia is a subcortical vascular dementia. And here what happens is it results from a cumulative effect of a series of small silent strokes. So no one notices it, right? But as more and more of these silent strokes occur, the problems that they cause are accumulated, and you'll find that the cognitive deficits set in. So if you look at the little scan picture there, you will see arrows pointing to white spots. So these are the features that can be seen on a brain scan, and which will be reported by the radiologist as chronic microvascular ischemia. So small vessels narrowed and causing ischemia to different parts of the brain. So again here, damage can occur in any part of the brain, and they can affect attention, memory, language. Difficulties also, as more and more of these white spots appear, there can be problems with speed of information processing and executive ability. All right. Okay, next slide. Here we talk about frontotemporal dementia. Again, similar to Alzheimer's disease, this too has a very insidious onset and gradual progression. However, the presentation is different. Again, two variants possible. A behavioral variant. So the individual presents with disinhibited behavior, and at other times very apathetic. They may be very repetitive in their actions, increase in appetite noted, dietary changes happen, and they lose that ability to empathize and sympathize with others. The prominent decline, as you can imagine, is in social cognition and executive abilities. Now, the second variant involves just mainly language. So it starts in the early stages with difficulties in speaking, in sentence structure. The speech may be slurred. There may be loss of grammar in the individual's speech. So those are the early stages before things progress. And in the language variant, in early stages, there's relative sparing of memory and learning. All right. Next slide. In Lewy body dementia, again, the presentation is different. So we heard about a gradual progression that we see in Alzheimer's disease, and in frontotemporal dementia, we heard about a stepwise progression with vascular dementia. In Lewy body dementia, the presentation is described as fluctuating. So there can be times in which this individual with Lewy body type dementia appears all right. Okay, and other times when all the symptoms, right, that they experience flare up, and they can present with a range of symptoms, different types of hallucinations, visual hallucinations and auditory hallucinations. They may have REM, sleep behavior disorder. They may have mood changes. They may become suspicious and experience paranoid ideas, right? And in later stages, there may be Parkinsonian features as well. So there's slowing, there's loss of facial expression, they may have tremors, right? So those are the features that we see in Lewy body dementia. And the main areas in terms of cognitive decline, initial stages are in complex attention and in executive function rather than memory and learning. Now, in this type of dementia, the basic pathology is abnormal deposits of a protein called alpha-synuclein. And these are the ones that aggregate to form Lewy body in the brain, right? So Lewy bodies will be seen on special magnetic resonance imaging and so on, and they can be picked up. Yeah. So next slide, please. Parkinson's disease dementia. Well, again, as I mentioned earlier, the important feature here is that the earliest presentation is not the cognitive decline, but the Parkinson's illness, right? So Parkinson's disease is diagnosed, and the longer the individual has, right, lives on with the Parkinson's disease, it's only at the later stage that the dementia happens, the cognitive decline happens. Here, so it's a very gradual, once again, a very gradual onset and progression. And associated features can be mood changes, there can be hallucinations, delusions, personality changes. Again, we see these REM sleep behaviors and sometimes excessive daytime sleepiness. So let me just explain what this REM sleep behaviors is. Basically, REM sleep refers to dream sleep. So the bed partner will often provide information to say during sleep, this individual starts shouting or may act out, maybe hitting out, kicking, and sometimes maybe even fall out of bed, right? So the inhibitory forces, which are usually present during our dream sleep and doesn't allow us to act out our dreams, are removed during REM sleep behavior disorders. And this is the typical history that they present with. Okay, so Parkinson's dementia. And the last slide that we want to look at, dementia due to traumatic brain injury. So as I mentioned earlier, the traumatic brain injury can be a result of a serious accident, a severe fall with skull fracture. There may be some penetrating injury to the brain as a result of either the accident or the fall. And in addition to that, the risks of dementia are increased if the traumatic brain injury is associated with loss of consciousness. There's amnesia in the post-recovery period. There's disorientation and confusion. And of course, in the more severe cases, right, you can get you can get neurological signs. So this diagnosis can sometimes be made in young people who have been involved, say, in a serious road traffic accident and multiple injuries, particularly to the brain. So it's not limited to someone in the older age group. Cognitive presentation, therefore, is variable. It really depends on which part of the brain is affected. And here we have some scans showing different areas in which there is extradural hemorrhage, there is subdural hemorrhage, there's intraventricular hemorrhage, and so on. So different types of damage can occur because of the brain injury. And importantly, in dementia due to traumatic brain injury, there's a great deal of disturbance in emotional functioning. So they tend to be irritable, frustrated, anxious, tense, and so on. All right, so just before I finish off this section, I think I just want to make two reminders for ourselves. Firstly, the diagnosis of dementia, remember, it must have both cognitive deficits and functional decline. All right, so just a cognitive deficit alone does not mean that this is dementia, right? So two parts to that diagnosis. Cognitive difficulties alone may be due to other mental conditions. So sometimes things like stress, worries, anxiety, depression can also present with some cognitive difficulties. And sometimes, right, sometimes it could also be a pre-dementia stage, right? So with those two important points, I'll end this part of my talk. Thank you, Prof. Kua.
Thank you, Professor Mahendran. You've given us a wonderful overview of the different types of dementia. So you see, when someone says, am I at risk of dementia? Dementia is a very complex and very broad description of a illness of the mind and the brain. And so it's good for her to clarify the different types of dementia. The commonest here in Singapore is Alzheimer's disease and vascular dementia. And as is mentioned, sometimes a combination. So now we're coming down to something more granular now, more focused now. Am I at risk? I've asked one of our colleagues, Professor Tan Ting Wee. He is our Executive Director of the Singapore Supercomputer. So he's very knowledgeable. He's going to tell us something about if you have one parent with a dementia, what are your risks? And if you have two, what are your risks? If you have brothers and sisters, then what are your risks? And so, Professor Tan Ting Wee, are you ready to
Yes, thank you very much, Professor Kua. Actually, thank you very much for inviting me. Both my parents now have dementia. So I obviously naturally think and wonder if, my risk will be heightened. Apparently, the whole range of the spectrum of dementia that is described by Professor Mahendran have different associations with inheritance. So, for example, if you have a particular gene like the ApoE4 gene, you may have a greater risk. So there are some types of dementia that have that risk factor. So in the case of my parents, I really don't know what kind of dementia that they have. So I don't really know. But I'm not taking risk here. I'm engaged in a lot of activities, including increase my physical activity, go for regular checkups, and of course, engage in cognitive activities, increase my social interaction, as well as be very careful when I have certain things that happen to me. For example, my dad had hearing impairment. So hearing loss is a serious problem that can eventually lead to reduction of sound input, auditory input, and this results in your brain switching off and reducing your cognitive, increasing your cognitive impairment as time goes on. So had we corrected his hearing impairment, for example, I suspect that we would have delayed the onset of dementia. And now my mother's turn to have dementia. And now more frequently, we see my mother-in-law also having this problem, repeating herself all the time and very forgetful. So these are examples whereby if we have relatives involved and blood links, you might want to pay a little bit more attention. Thank you.
So, okay. Professor Mahendran, you want to expand on this?
Oh,
the
okay.
risk is your
thanks.
one parent, what the risk of two parents, brothers, sisters, Okay.
Okay, thanks. Okay, I suppose I start off by actually saying that the majority of dementias are not inherited by children and grandchildren. In the rarer types of dementia, yes, there may be a strong genetic link, and I think I did mention about Huntington's disease and dementia, but these form only a tiny proportion of overall cases of dementia. Okay, so some background about genes, right, and what role they play. There are two types. One, the causative genes, or sometimes the word deterministic gene is used. So if one inherits this sort of gene for a certain illness, then they will certainly develop that illness in life. And the second one is risk factor genes. Now, this only slightly increases the risk in developing the disease as compared to the average population. So let's go on to the next slide. So in the case of Alzheimer's disease dementia, the most important risk factor really is age. Alzheimer's dementia is common in people in their late 70s, 80s, 90s. So having a parent or grandparent who developed Alzheimer's dementia at these late ages does not change a person's risk compared to the rest of the population. So that's an important point. Now, the most important gene, right, and it was actually discovered in 1993 for dementia risk, is apolipoprotein E gene, all right? And there are 3 different types, 2, 3, and 4. And they can occur in any combination. You can have 2 2s, 2 3s, 2 4s, or you can have mixed types, 2 and 3, 2 and 4, 3 and 4, and so on. But everybody carries these genes. Now, what we do know is the most common of these apolipoprotein genes is ApoE3. It's the commonest. Up to 80% of the population has it. However, the presence of this neither increases or decreases the risk of Alzheimer's dementia. ApoE2 genes, right, if you have both of them, may decrease the risk, but again, we don't know why. So this is just from population studies, but nobody knows why having the ApoE2 may actually be like a protective factor. Now, ApoE4, especially with individuals with two of the same type present in them, there is an increased risk of Alzheimer's dementia. But again, population studies have shown that up to 50% of people, right, who are aged in the 80s and above, and carrying the ApoE4 genes do not have dementia even at that age. So again, the type of apolipoprotein gene a person has is not enough on its own for a diagnosis of Alzheimer's disease. Okay, so next slide, please. So there are, I hate to say this, but there are rare forms of Alzheimer's disease, less than 1% of Alzheimer's disease, where there is a hereditary component. So it's referred to as early familial Alzheimer's disease. And in these cases, the families will actually have a history of members developing dementia in their 40s and 50s, all right? Now here, as I mentioned, is a very small group, and we do know what these particular genes are. Presenilin 1, presenilin 2, and amyloid precursor protein gene have been identified, all right? So for this particular group of individuals or families, right, rare, but in them, they will carry these genes, and if these genes are mutated, then they are at increased risk of developing Alzheimer's disease. But maybe if I move on to the next slide, I think what may be more important, and Prof, do you mind if I go on to talk about modifiable risk? Okay, so I think rather than being worried about genes, do I have it, am I carrying it, what's my risk? I think what is more important is the list of things that we can do, the risk factors that we can modify and are known to be able to modify dementia. Now, this is a list that came out from the Lancet Commission in 2017. And 3 years later, they added on the 3, you see at the bottom of the slide, they added on 3 more things. So this is the whole list of things where they say that you may carry at-risk genes, for example, for hypertension and diabetes, but you can do something about it to prevent deterioration and further cognitive decline by actively working on it. And so just like Prof Tan mentioned, that he makes every effort, right, to exercise, to make sure that he remains healthy and so on. So these are the important things that we should focus on and what we can actually do to help ourselves. So like having good control of hypertension and diabetes, making sure smoking is out, and like was mentioned, hearing impairment, making sure eye, vision, and hearing is checked and there's no impairments there. Ensure that we are physically active. In a recent study that we did in the community, we found that although people were doing some exercises, it wasn't optimal, it wasn't sufficient to what is recommended. So physical activity is important, right? Again, excessive alcohol consumption, we did talk about it just now, that how in the longer term it can lead to dementia, and some things really beyond our control, right? Traumatic brain injury, education, air pollution are not within our control, but there are numerous things that are within our control and that we can work on to help ourselves. All right. So I will stop there, Prof.
Yes, the point Professor Mahendran emphasized earlier on is that most cases of dementia we see in our clinic are not inheritable. So we started the first memory clinic in Asia in 1990. So there's massive data, and most of the cases are not inheritable. I have only seen 2 families. I look after a doctor and his 2 sisters. All of them have dementia. But then the good news is we help them out and improve the quality of life. and they live on to ripe old age, about 85, 86, with good quality of life. And so that's very important. You may have dementia, but it's not the end of the line. And there's people have this fear. I remember seeing a patient referred to me from Malaysia, brought in by the mother, brought in by the daughter, and when she asked me about, once again, this question, am I at risk? And I told her that it doesn't mean your mother has dementia, that means you will have dementia. Dementia is not, the gene is not inherited as a dominant gene, all right? It's not a dominant gene. And but then she began to cry and said, well, it looks like I'm at risk, Then I told her that she's a lawyer. So I told him that, told her, sorry, that you also inherit the genes for intelligence from your mother. And she's quite a charming lady also. So all these things we often forget. We blame our parents for all the kind of this illness we have, but forget they give us a lot of other good genes. So so the good point is most cases are not inherited. So I think we shall press on with the next area, because even you have a gene that you have the illness or you have a risk of the illness, what can you do to prevent? So, Professor Mahendran, you want to press on?
Okay, so let's focus on vascular dementia. I think that's an area in which we have a lot of data, and we do know that it can, potentially it can be prevented. Can we move to the next slide, please? Yeah, so we do know that potentially it can be prevented with good control of the underlying causes, such as blood pressure, diabetes, high cholesterol levels. So ensuring that we are compliant with treatment, we have regular checkups and follow-ups would be important. Now, most at risk of strokes, remember we said that strokes, there are two types, so strokes, right? Those with hypertension who are more than 60 years of age, who are overweight, who smoke, who drink excessively, have heart conditions, high cholesterol level or diabetes, they are the ones at highest risk of strokes. So really, if you do something about it, if you look after yourself, you actively work in these areas, then you can effectively reduce the risk of strokes and reduce the risk of vascular dementia. Now, in the case of the really small microvascular strokes, the silent strokes, again, high blood pressure is also a risk factor. So paying attention to that, making sure that there's treatment and follow-up, again, you can help oneself by preventing this. Now, other threats to blood vessel damage, which contribute to vascular dementias, smoking, high cholesterol, diabetes, obesity, sedentary lifestyles, and heart problems. So all of the things that really the Lancet Commission had already told us about are becoming important things that we can do something, we can use it to prevent vascular dementia. So definitely research has shown that regular exercise, a healthy diet, balanced diet, right? Especially in midlife and beyond, it helps lower our risks. And controlling chronic ailments, for example, quitting smoking and regular cognitive activities to stimulate our brain. All of this could help delay the onset of dementia. The next slide, I think, or do you want me to go on a little bit, Prof Kua? I think I can just briefly talk about
one more slide.
Yeah, just one more slide.
Sure.
Okay, so in terms of treatment for vascular dementia, there's no specific treatment for it, unfortunately. So what is recommended is really looking at the underlying related conditions. So same thing, I'm going to be repeating myself, medication for diabetes, for high blood pressure, high cholesterol. If there are heart problems, then necessary cardiac interventions for those can help in reducing the risk and, of course, enhancing cognition if there is Alzheimer's disease or vascular dementia. There's also a role for other areas. In vascular dementia, we said there are risks that neurological deficits may occur. There may be a stroke leading to weakness on one side and so on. In those cases, definitely active physiotherapy and rehabilitation play a big part, right? Occupational therapy and speech therapy if speech areas are affected in the brain. So patients also benefit from cognitive therapy. So there can be activities which are designed to stimulate thinking skills, and how to engage with others and communicate. So cognitive therapy does help. And definitely group-based sessions, such as games, they provide the opportunity for socialization and enjoyment. So these seem like simple things, but research has shown that they do help, right, in those at risk of vascular dementia or those who already are in the early stages. You can help reduce the risk of further deterioration. So I'll stop there, Prof. Thank you.
Thank you very much, Professor Mahendran. I want to ask Professor Tan Ting Wee. He mentioned about his risk. So there's a race against time or dementia. So Professor Tan, what are you doing for yourself? Can't hear you.
Yeah, thank you very much for that question. Because of both my parents have dementia, so I'm not taking any chances for the risk factor, whether it's genetic or not. So actively involved in all kinds of points that have been raised by Professor Mahendran. Keeping active, but not just keeping active alone, but doing things like engage in networks of friends. So combining two things. We know we have to do physical. We also know that we need to be socializing. Why not combine the two, right? And then be involved in all these cross activities that involve more than one element, right? So, for example, if you are worried about the nutritional aspects, right? Eating well, reducing your alcohol. Try to make sure that I'm involved in a social network of friends that eat well together after an exercise. So these kinds of combinations help along the way. Alternatively, there is also something that I have to monitor, because it was mentioned that micro strokes can take place as we age, right? And these transient ischemic attacks, for example, can lead to a more severe stroke. So one needs to be able to detect when I'm going to have that transient ischemic incident and when I need to take action before the bigger stroke comes in. So I make use of things like playing with Rubik's Cube, right? Speed cubing, because it involves the physical, the tactile, the cognitive, combined with the visual. So these are things that I am involved in. Learning a new, playing a new instrument, learning new guitar pieces, which I'm involved in, keen interest in. So these are things that I combine together in order to A, detect, B, prevent, and C, take action should I detect any decline in any of these activities, and then to seek medical help. Thank you.
I want to ask Professor Tan something a bit more personal. Do you sometimes have a bit of anxiety that at the back of your mind, and listening to Professor Mahendran and listening to all the doctors and all that, does it send a chill up your spine sometimes? So how do you deal with it then? This anxiety that, well, I have dementia, this risk, Yeah, I know you're doing a lot of work, In fact, Professor Tan is helming a caregivers group, outside there and doing wonderful work. And I'm sure many people with family members with dementia have some anxiety, a bit of fear lurking. How do you deal with it?
Well, everybody has their own ways of dealing with all our deepest fears. In my case, at my age, 61, I have lived enough, I think. And every day to me is a last day. Every day that I wake up in the morning, it's a bonus. Having said that, live as if this day were the last, but learn, be planning as if there is no tomorrow.
Yeah, I see. I think that's wonderful advice. Professor Tan Ting Wee comes from ACS, Anglo-Chinese School. The motto is "the best is yet to be." I think that's very good. I meet him often as we go walking in Botanic Gardens on a Saturday morning at the crack of dawn, and he's always there. He's always very positive, and so keeping yourself positive is very important in the sense of hope. So, and also because when he joins us for the walk in the Botanic Gardens, there are a lot of friends around you. So I think that's good, and so this kind of support you have in the community helps to reduce your anxiety. I want to show you very quickly what the Mind Science Center is. But before that, thanks, Ding Wei, for your contribution. I want to show you what we're doing called the Age Well Everyday Program. I'm sure you have heard of this program. Maureen runs so fast, I don't know where is she now. Yeah, you're right. Okay, so this program comes about as a translational research. We've done a lot of almost 10 years study at Jurong on the dementia prevention. And I'm going to tell you all for the first time, you'll be hearing it. I've released the data to all of you. You're privileged before, because we're supposed to present it at a conference. I'll tell you that the Singapore Ministry of Health has stated that the prevalence of dementia in the community is 10% for people above 60 years. So if there are 100 people who are above 60 years, then the number of cases is 10. But in our Jurong study, for people above 65, we found that the prevalence is only 3%, because there are a lot of activities over there besides health education to stabilize hypertension, diabetes. There are also activities on music, art, mindfulness, gardening. And so all these activities help to stir up the brain and help the memory and the concentration of these people. So it's very good news. If you have 10% of the population in Singapore above 60 with dementia, its absolute number is almost 100,000 people. That's quite a lot of people, you know. But if you can reduce it to 3%, means that you're just about 30,000 people. So you prevent or save about 70,000 people, right? So what we have this program, I'm going to show you very quickly. It's called the Age Well Everyday Program. Initially, it was called the Dementia Program, but dementia has a stigma. So people were not keen to be in part of the program. So we changed it around, have something more positive, Age Well Everyday, or AWE program. So next one, you see that there are 5 components: exercise, horticultural or gardening, health education, which is pivotal because you can control hypertension and diabetes. Then that's about how the battle is won. You know, when we first had this idea up, you know, there was a lot of misgiving. People doubt whether is it true? Is that a link between hypertension and diabetes in dementia? But we say that the data is overwhelming from memory clinic. So now after almost 10 years, people agree that if you control hypertension, diabetes, then half the battle is won. So we also have music, art, and also mindfulness practice. Next one. Okay, so we also have a e-learning, because it's very difficult to train people all the time, coming to the university here for training. So there's e-learning, and if you are eager to, I think you can get on the QR code, but it's moving so fast. Right. Can they capture it if you want to? Oh, yeah. Jonathan, can you capture it if you want to? I think Jonathan is watching. He's somewhere in Singapore with all his friends and family. This computer system in NUS is not very good, I'm afraid. There you go. Yeah. If you, I don't know how we're going to get back again. Can you? Yeah. I hope, Jonathan, you can take a picture of it. And then you can get onto it. There you go. Because I think I must ask the NUS to invest in a better computer. Yeah. So now there are about 7-8 centers in Singapore, and whatever research we do must be impactful in people's life. It's no use to do research, there's no one benefit at all. So this study is going to benefit lots of people in Singapore. And by the way, people in Malaysia, if I'm listening from Batu Pahat, we're going there on the 16th of April to run a program there. Is that the last slide we have? Right. Okay. So you can contact, if you are living in Singapore and you say, I heard about it, but where can I seek more information? So there are about 7 centers that you can go out to, and there's a QR code for you to find out more. And then you want to contact us again, you can also go to our website, which I think Maureen will tell us later on. And so we want to contact all of you. I think there's a big race to reduce the prevalence of dementia, because the figures at 10% is just too high. Can you imagine 100,000 people in Singapore with dementia? The cost is phenomenal, and we are working with our economists from NTU, Professor Kua is going to help us out, to see how we can prevent this and save so much money for everyone. Okay, I'm going to come to an end, but I think there's time for some questions. And I've heard that there are a lot of questions. I'm going to ask Professor Mahendran. Early symptoms of, what is it? Where can I go for dementia tests? Perfect.
Sorry, okay, I mute myself. Okay, I think good question. So if you're concerned about yourself or you're concerned about a family member or friend having difficulties and you think that this could be dementia, don't jump to any conclusions, seek proper assessment. Now, this can be done at a polyclinic, can be done by a family physician first, as a first cut. So usually they will take history from you, right? And try and establish that, yes, this is just a pure cognitive issue, or maybe it could be other mental health conditions which are also contributing to these difficulties. And so if they do think that there is a necessity, then they'll refer you to memory clinics, which are present in various restructured hospitals. So what is nearest to your home, that's where they'll refer you. And at the restructured hospital, when you go to a memory clinic, again, the doctors will go through the history. They will do brief cognitive assessments, which can be quickly done. A mini mental state examination, a Montreal cognitive assessment. These can be done very quickly to assess what the situation is like. They might also recommend blood tests to be done. And they may also recommend CT scan of the brain. Now, blood tests, because sometimes, right, say low levels, nutritional deficiencies in, say, vitamin B12, folate, can also contribute to cognitive problems. So definitely, they will want to do those kind of screening tests for you. Now, if they think that this is really something serious, there's also a history of functional decline, then they might recommend a proper full neuropsychological assessment, which may take an hour or two, and that is done by a clinical psychologist. So that's the way forward to getting testing for dementia. But as a first off, sometimes we get very worried, right? Anxiety, just worrying about things, and we jump to the conclusion, could this be dementia? So the first cut, see a GP, relate the history and the problems, let them assess and decide whether you need specialist assessment. All right, I hope that answers the question. Yeah.
Good, good. I think the second question is, are young adults at risk of dementia? Professor Tan Tin Wee is a very young adult. He has no dementia. I can assure you that. So, Professor Mahendran, what do you think? Are young people?
So again, it really depends on what type of dementia that we are talking about. So if it is really something which has a very strong family history, and I go back again to my same Huntington's disease and dementia, of course, many family members have the illness, and that usually starts in the 40s. Now, where it is due to traumatic brain injury, yes, it can happen in a young person, say, who wasn't wearing a helmet, riding his motorcycle and was involved in a serious accident in which there was severe head injuries. Yes, that dementia can develop. But by and large, and of course, the other group is the familial type of Alzheimer's disease. Again, very few, less than 1%, and there will be strong family history. So in those, the dementia can appear much earlier. But by and large, as I mentioned, most of these dementias don't occur in adulthood. They usually occur in older individuals. So we are talking about 65 and upwards that these kind of things happen. Yeah. And of course, stroke, if it does happen in their 50s or something, carries the risk of dementia. So it's very difficult to answer that question because it really depends on what area or what type of dementia is possible. Yeah.
Sure. Another question is very common. Are patients with dementia aggressive, and how do you manage? Maybe I'll ask Prof Tan again. Are any of your parents aggressive? And
yeah, my dad had this problem. So we actually did not know. That was the big problem. We thought he was getting old and cranky, But in actual fact, the underlying dementia was already onset. And we attributed his abusive behavior because, he was irritated and so on. So he started abusing that. Actually, it was behavioral change due to dementia.
Okay.
So this was a concern which well, I wish in retrospect that we had detected it earlier. And a lot of it boiled down to his uncorrected hearing impairment. So he refused to wear his hearing aid, and we let him be. But had we corrected for it, I think he would be in a much better state today. And it turns out that we had to buy the $5,000 and above type of hearing aid because the lower level hearing aids are useless. They amplify ambient noise and makes it worse.
Okay.
So we didn't know that, you see. So we thought, wow, you throw away a $2,000 hearing aid. What a waste, right? Okay, you don't use it. Then that led to his severe decline.
Yeah, good. Thank you very much for that. I think I agree with you. Because I've in this field for almost 35 years, I haven't seen any of my patients who are aggressive. Maybe not aggressive towards me, but even if they're aggressive, you think about it. I spoke to one. They complained to me that the father was aggressive. Often more the men than the women. But later on, when I talked to this man, it's his fear, because he told me in the evening sometimes he would see ghosts walking around his house. He saw his dead father coming. He got his fear being translated, to his irritability. He's trying to ward off this kind of vision that's troubling him. And then people say, "Oh, as you said, like, you are cranky, you're disturbing me." And often, if the caregivers cannot sleep, then that becomes a problem. So if you can preempt this with information, you talk to your doctor, if you can allay the anxiety of this elderly person, that'll be wonderful. You can sleep well. And I tell people always to keep a small light on, because you wakes up in the middle of the night, you see a lot of shadows, you misconstrue the environment, you think, oh, that's a ghost coming to get me and all that. Now, you say something, Tingwee?
Yeah, so this is a very important point, because my father ended up fighting with the mom, and then they got fractured, and then they fell and so on. So it turns out that the caregiver, the people surrounding the person with dementia, is very, very important. And to a certain extent, they are classified called caregivers, right? Okay. And we didn't realize this. So my mom lived alone with my father. And as a result, her own dementia system accelerated as a result of this constant friction, verbal to physical fights that they had. So this was a very serious traumatic experience for our family. And we failed to recognize that it was actually underlying cause is dementia.
Okay, I agree. Yeah, because even the diagnosis itself, dementia, is a very frightening diagnosis. So I know one particular doctor, it was so difficult, refused to see anyone. So the wife asked me to see the husband, and you got to approach it very gingerly. You have to be careful. I'll tell him you have memory problem, but I'll tell him that there are many things you can do to improve your quality of life. Don't say you have dementia, you're finished, your life has come to an end. Don't tell them that. Another doctor told me he was told that there's no treatment, that's the end of my life. No, there are a lot of things that can be done. Someone asked, what can I do? You have dementia. Okay, you see a doctor. There are many things the community now, I think the government is helping to do many things. Sometimes Singaporeans like to complain all the time, the government not doing enough. A lot of things being done. And the good news is there's an Age Well Everyday program. You can go down there, there's 6 centers, you go to these centers and they can tell you more. All right. I know that time is running out and time is premium in this kind of webinar, which is about 1 minute. I'm going to ask Maureen any last minute questions or information for all of you. But before that, I'm going to thank Professor Mahendran, Professor Tan Ting Wee, and of course, our benefactor, Professor Hong Hai, who is a board member of the Mind Science Center. Okay.
Okay, everyone, we're reaching the end of this webinar. Thank you so much for coming. Thank you so much for spending your lunchtime with us today. It has been a really informative session, and I hope it has really helped give you some knowledge and some power to be informed about this disease and what you can do to prevent it. So yeah, don't worry, if you miss anything, this webinar will be recorded. It has been recorded. It will be published on our website very, very soon. And we do have a lot of questions that because of time, we cannot really answer, but not to worry, we will save them all and we will upload it as a webinar highlight later on. So we'll be in contact with the 2 speakers to try to answer some of these questions later on. Very sorry for it, and really sorry for the technical issues just now. I hope you have enjoyed this webinar. And to end, please help us fill up this feedback form so that we can know what you think about this webinar and we can be better for the next run. Thank you so much for today.